right. All right. Are you guys able to see? Oops, let me get to the beginning.
No worries.
Are you guys able to see the slides?
Yes.
Okay, perfect. All right, so today I'm going to be talking about thyroid diseases. So just a brief outline of today's talk. We're just going to look at neck anatomy and thyroid lab testing to start with, and then we'll go into hypo and hyperthyroidism and just briefly touch on thyroid emergencies, which is more of what we see in the inpatient setting. In terms of neck anatomy, so just a reminder, the thyroid sits basically right in front of the trachea. The recurrent laryngeal nerves sort of go behind the thyroid and innervate the muscles of the larynx. So when you think of, when patients have thyroid surgery, what sort of complications they can have, sometimes they can hit those laryngeal nerves. Or when you have a patient who has thyromegaly, you can get compressive symptoms. So some shortness of breath or voice changes, and that's because of its proximity to the trachea and to the recurrent laryngeal nerve, sorry. This is just an axial view of how you would see a thyroid on ultrasound. So you would see the isthmus of the thyroid in the middle here, right in front of the trachea, and then the right and left thyroid lobes. So just talking briefly about thyroid physiology, the thyroid gland is controlled by the hypothalamic pituitary axis. So your hypothalamus releases thyrotropin releasing hormone that then works on the pituitary gland to release TSH, and the TSH then works on the thyroid gland to release T4 and T3, which are your active hormones. These are the thyroid studies that we typically order, and basically I'll go through which ones we order, when, and why, but free T3 and free T4 are your active hormones. They're bound to a protein called DPG, and that's what makes up your total T3 and your total T4. And so we'll look at when to order those tests. This is a helpful chart from UpToDate. So this is basically just showing you different patterns of thyroid hormones and what that means. And so we're going to focus on the stuff that I've highlighted in the red box, but I think it's just a good quick reference. So after you order thyroid labs on a patient in the outpatient setting, if you're sort of not sure what that pattern means, you can pull up this chart, and I think it's a pretty helpful reference there. A couple of things to keep in mind when you do order a thyroid lab. So there are some things that can affect the thyroid lab, so that you want to ask the patient about. So one is biotin, and that's one that we do see commonly. So patients do take biotin in hair and nail supplements. So typically the biotin that's just in a multivitamin should not affect the thyroid labs, but biotin that's found in hair and nail supplements at higher doses can affect the thyroid labs. So it affects the thyroid assay. So if a patient is on biotin, you want to ask them to hold it for about 3 to 5 days before they get their thyroid labs. Not all assays are affected by biotin, but it is common that we see, a problem with the labs in patients who are taking the higher doses of biotin. What you might see when a patient is on biotin is a low TSH and an elevated T4 and T3. So it kind of looks like a hyperthyroid picture, even though if you have them stop the biotin, their labs may completely normalize. Pregnancy can also affect your thyroid lab. So in pregnancy, you have increased estrogen, which increases your thyroid, your TBG, or that protein that binds to the hormone. And so that's just something to keep in mind. In pregnancy, you can see higher levels of T4 and T3 because of that. And then non-thyroidal illness. So basically non-thyroidal illness is, your thyroid labs may be affected in critical illness. And this is a body's actually adaptive response to mitigate catabolism in severe physiologic stress. So it's sort of a normal response. But even if the thyroid labs are off, it doesn't mean they actually need any sort of treatment. In non-thyroidal illness, you typically see a decrease in all the labs. So low TSH, low T4, and low T3. And again, the body is sort of shutting itself down to mitigate that catabolism that can happen. So moving on to hypothyroidism. So some common symptoms of hypothyroidism, and a lot of them, some of these can be non-specific and can have other causes, but patients can describe fatigue or depression, cold intolerance, weight gain, bradycardia, constipation, puffy skin, menstrual problems. And their thyroid on exam can be anything from enlarged to normal or small. So the thyroid exam may not help you in terms of determining that it's hypothyroid, but the labs will certainly help. And these are some of the symptoms that they may describe. So how to diagnose this is, diagnose based on lab. So your TSH will be elevated and your free T4 will be low. So TSH goes in the opposite direction because it's the signal from the pituitary gland. So if the pituitary gland is seeing that the thyroid is making less thyroid hormone, so your T4 levels are low from the thyroid, the pituitary gland is sort of going to ramp up its message to tell the thyroid to make more thyroid hormone, and that's why it goes in the opposite direction. So that's just an easy way to remember that for hypothyroidism. Because many times we do get consults where it will say hypo or hyperthyroidism, but the labs sort of show the opposite, so it can get confusing. Here's some common causes of hypothyroidism. So you can have congenital hypothyroidism. That's more probably seen in the pediatric setting. What we commonly see in adults in the outpatient setting is Hashimoto's thyroiditis. So this is a very common, this is the autoimmune disease in which antibodies can act against the thyroid and cause destruction of the thyroid gland over time. In Hashimoto's thyroiditis, you can check that by checking TPO antibodies and thyroglobulin antibodies. So TPO is thyroid peroxidase antibodies, and those antibodies will be elevated in most patients, and many patients, I shouldn't say it's not all patients, but in many patients with Hashimoto's thyroiditis. These antibodies are non-specific though, so they can also be elevated in Graves' disease, which is the autoimmune form of hyperthyroidism. So basically, if you have hypothyroidism along with TPO, that does tell you that they have Hashimoto's. You can have non-immune mediated destructive thyroiditis. Patients who have radioactive iodine for treatment of Graves' disease or of other hyperthyroid can then develop hypothyroidism. Of course, patients who have surgery by removal of the thyroid for things like thyroid cancer will have hypothyroidism. And then some medications to keep in mind. Lithium does affect the thyroid. It can cause either hypo or hyperthyroidism. Same with amiodarone. Amiodarone can also cause hypothyroidism as well as hyperthyroidism. And a lot of the new, some of the newer medications that we use for cancer, checkpoint immunotherapy that they're using in a lot of different cancers like melanomas that can also cause issues with your thyroid. So we see that commonly from our cancer patients. So treatment for hypothyroidism is relatively straightforward. You just want to replace their T4 that their thyroid is not able to make. So you give levothyroxine at a dose is generally a weight-based dose. So full replacement dose is 1.6 micrograms per kilogram. The main thing you want to make sure is that your patients know when to take it and how to take it. So it is affected by food. So they should take it first thing in the morning on an empty stomach, just with water. They should wait at least 30, we say, 30, anywhere from 30 to 60 minutes before eating. And then one thing to keep in mind is that iron supplements, calcium, and multivitamins with calcium can affect the absorption of this medication. So you want to separate that by at least 4 hours. So if they're on any sort of multivitamins, make sure they're taking it at least 4 hours apart. After you make any adjustment to your dose of levothyroxine, it typically takes about 6 weeks before you see that reflected in the TSH. So you'll check your repeat labs about 6 to 8 weeks later after a dose adjustment. There are certain populations that you want to think about when dosing levothyroxine. So in some of our elderly patients, especially in those with coronary artery disease, it can cause increased angina, and we want to be careful. So we typically start much lower in our older patients. And so you can start with lower doses like 25 to 50 micrograms and slowly titrate up. So it may not be, you may not want to start, right at that weight-based dose because that could cause issues with the heart. Also, if patients have like history of AFib or irregular heart rhythms, you also want to be careful because if they become hyperthyroid, that can sort of exacerbate their irregular rhythms or AFib. And pregnant patients, they usually have increased requirements of thyroid hormone. So once a patient is pregnant, we want to check thyroid labs right away. Generally, they need an increased dose, about 30% of what they're already taking. And so usually we increase their dose right away by an extra 2 pills, right in the first trimester. And then we check their labs monthly, especially in the first and second trimester during pregnancy. And then after they deliver, they generally go back to their normal pre-pregnancy dose if they were well controlled on that. So what is subclinical hypothyroidism? Subclinical hypothyroidism is when you have an elevated TSH and a normal free T4. So there's not a lot of evidence to support that you have to treating subclinical hypothyroidism. So when a TSH is mildly elevated, so if it's anywhere from 4 to 10 with a normal T4, we actually don't generally treat, unless there's a couple instances where you could consider treating in those. One is if a patient is very symptomatic and you want to sort of try and see if they improve with a low dose of levothyroxine, you could treat. If a patient has positive TPO antibodies and they're sort of heading in that direction, so their TSH is rising 9 or 10 with positive TPO antibodies, they're likely going to need thyroid hormone in the future. And if they're already symptomatic, you could start them on treatment. And then in pregnancy, so in pregnancy, we have stricter goals, and we want to keep their TSH less than 2.5. And so if they if they have subclinical hypothyroidism in pregnancy or in patients who are having trouble getting pregnant and infertility, then we're sort of more aggressive about treating the subclinical hypothyroidism. Once that TSH starts rising above 10, then you do want to treat them. So moving on to hyperthyroidism. Hyperthyroidism has the opposite symptoms than hypothyroidism. So these patients can be nervous, irritable, they might be tremulous, they can have palpitations, tachycardia, arrhythmias, weight loss as opposed to weight gain. In hypothyroidism, we see the constipation, but here we see more frequent bowel movements. Again, fatigue you can see in both, and you can see menstrual irregularities in both hypo and hyperthyroidism. So working up hyperthyroidism is a little bit more complicated than hypothyroidism because there's more causes. So you could have Graves' disease, which is an autoimmune disease in which you have stimulating antibodies against the TSH receptor. Graves' disease is also associated with eye disease. So some patients also have sort of those bulging eyes, proptosis that we see. Another cause, I generally think of, 3 main causes when a patient comes in with hyperthyroidism, or trying to figure out which of the 3 causes it is. So is it Graves' disease, or is it that autoimmune problem? Is it a hyperfunctioning or hot nodule, or is it thyroiditis? So thyroiditis, there can be multiple causes of thyroiditis, but you can basically have, painless thyroiditis, or a thyroiditis caused by the immune checkpoint inhibitors that we had mentioned earlier, or subacute thyroiditis. So those are sort of the 3 buckets that I think about when a patient comes in with hyperthyroidism. And we'll talk about how to sort that out. So other causes are early pregnancy. You can see changes in thyroid hormones that make them appear hyperthyroid, or congenital hyperthyroidism. But generally, those 3 buckets are the main things that I think about. So what do you see in hyperthyroidism? You see a low TSH, and then you see elevated T4 and elevated T3. So how do you sort out what is the cause of hyperthyroidism? My first step is to check a thyroid stimulating immunoglobulin and a thyrotropin receptor antibody. So those are 2 blood tests. So once a patient has hyperthyroidism on their labs, I check these antibodies. That's looking for Graves' disease. If those come back positive, you have your answer and you don't really have to do further workup. So if those come back positive, this is Graves' disease and you can start treatment. If those come back negative, then you can think about an uptake and scan. So an uptake and scan will show you basically which part of the thyroid is producing more thyroid hormone. So is it the entire gland, or is it a hot nodule, just one area making more thyroid hormone, or is it thyroiditis, in which case you'll have zero uptake on the uptake and scan. And I have pictures to show you in a second here. A thyroid ultrasound with vascularity can also help. So a thyroid ultrasound can never diagnose the reason of hyperthyroidism, but it can always be supporting. And it's a good idea to get an ultrasound either way, because you do want to look for underlying nodules as well. But basically in like Graves' disease, you'll have increased vascularity. In thyroiditis, you would see decreased vascularity. So it can sort of help support your diagnosis. This is an uptake and scan. So as you can see, so just sort of pointing out a couple of things. Down here, you see thyroiditis, so you get zero uptake. In Graves' disease, you'll have bilateral uptake, so you'll basically see uptake in the entire gland. If it's just an autonomous nodule, you might just see one area or a hot nodule, one area that's lighting up and that's showing an increased uptake. So how do you treat hyperthyroidism? It does depend on the cause, but a lot of both for Graves and hot nodules, you basically have sort of this similar treatment options. So in Graves and hot nodules, it's a problem with overproduction of the thyroid hormone. So you can do medications. You can put patients on methimazole or PTU, and that will help to bring down their thyroid levels. Generally, we start with methimazole because it has less hepatotoxicity as compared to PTU. However, PTU is generally used in the first trimester in pregnancy. So that's the only exception of when we may think to use PTU first. You can give radioactive iodine for both Graves' disease and a hot nodule. You can do surgery or beta blockers. Beta blockers can control the symptoms actually in both cases. In terms of deciding which one to go for, so it's not always clear, and sometimes it's based on patient preference. So in Graves' disease, sometimes patients do have remission of their Graves' disease after about a year to year and a half of treatment with medications. So you don't have to go for more permanent treatment options like radioactive iodine or surgery. If they're willing to take the medications and if they're tolerating it okay, you can just start them on medications and see how they do. If they have side effects to medications, then you may want to think about doing those other more permanent treatment options like radioactive iodine or surgery. With radioactive iodine and Graves' disease, one thing to keep in mind is after they get it, they will become hypothyroid because in Graves' disease, you're killing off the entire thyroid, so they'll be on lifelong levothyroxine. Surgery, of course, will also cause lifelong hypothyroidism because the entire thyroid is removed, and so they'll be on lifelong levothyroxine. In a hot nodule, if you give radioactive iodine, the goal is to only kill off the area, the nodule part, and the hope is that they become euthyroid after and they don't need medications. However, there is always a risk that more of the thyroid gets killed off than you want it to, and they end up on thyroid medication. So that's always a risk you need to discuss with your patient. So those are sort of the different treatment options. Generally, what I do for Graves' disease is I usually start with medications because, like I said, some patients will go into remission and then they don't really have to undergo radioactive iodine or surgery. But I have had patients who can't tolerate medications, and that's when we start thinking about those other options. You want to avoid radioactive iodine in patients with Graves' disease who have eye issues. So if they have the thyroid eye disease, because it can actually make it worse. And so that's another thing to keep in mind. All right, so moving on to destructive thyroiditis. So basically in destructive thyroiditis, your thyroid releases a bunch of hormone. So it's not a problem with overproduction, rather it's a problem with destruction and release of the already preformed hormone. So in thyroiditis, you generally see a phase of hyperthyroidism followed by hypothyroidism. And usually over time, these patients become euthyroid and their thyroid sort of recovers and goes back to normal. So because it's not a problem with overproduction, medications like methimazole and PTU won't work in these patients. So really, the treatment is just time. Things will get better over time. If they have pain because it's a subacute thyroiditis, you can give NSAIDs or steroids to help with the pain. And then you can give a beta blocker when they're in that hyperthyroid phase to help with the symptoms. Sometimes patients, when they go into the hypothyroid phase, if it lasts a long time or they become severely hypothyroid or they're pretty symptomatic, you can give short courses of levothyroxine as well. And then when things start to get better, you can sort of back down on the doses and see if they truly need to be on it lifelong or if they can get off of that levothyroxine. So this is a good, this again also is from Up to Date. So this is just how to dose methimazole. So I think it's helpful. It's like how to think of initial doses of methimazole. So basically you're looking at your free T4 levels. If it's 1 to 1.5 times upper limit of normal, we generally start at 5 to 10 milligrams a day. If it's greater than 1.5 to 2 times upper limit of normal, we generally think of 10 to 20 milligrams daily. And then if it's greater than 2, then upper times normal, then you start thinking of higher doses like 20 to 40. The only time, like I said, that you think of doing PTU instead of methimazole is generally in the first trimester of pregnancy because of decreased effects to the baby. And then you can switch over to methimazole in the second and third trimester. So I wanted to touch base on subclinical hyperthyroidism. So in subclinical hyperthyroidism, you have a low TSH, a normal T4, and a normal T3. Subclinical hyperthyroidism can also be a little bit tricky because sometimes you treat it and sometimes you don't. So you don't always have to treat it. In young patients who are premenopausal and not having any symptoms, you may just watch it and sort of monitor their labs over time. However, in patients who are greater than 65 or postmenopausal, subclinical hyperthyroidism can be associated with bone loss and AFib. And so that's why we do consider treating it in those populations. So this is a good chart. This is from the American Thyroid Association guidelines. And this tells you when to consider treating and when you can just consider observing. In any patient, if they're symptomatic and they have subclinical hyperthyroidism, that automatically you can try treating and see if their symptoms improve. And so I think this is a good chart. So if they have if they're greater than 65 years of age and they have a completely suppressed TSH, you do want to treat. If they have sort of a TSH that's low but not completely suppressed, 0.1 to 0.4, you can consider treating. If they're less than 65 but they have comorbidities like heart disease, osteoporosis, hyperthyroid symptoms, you always want to treat with a low TSH, and you can consider with a suppressed TSH, completely suppressed TSH, and you can consider treating with a TSH of 0.1 to 0.4. And then if they're less than 65, but they're asymptomatic and their TSH is 0.1 to 0.4, you can just observe them. So that's a good guideline. All right, and we're actually almost done here. I'm just going to finish up with thyroid emergencies. These are more in the inpatient setting. So really for outpatient providers, it's just sort of when to recognize of maybe when to send them to the emergency room. So Thyroid Storm is an emergency, so they need to be admitted if you think a patient is in Thyroid Storm. So Thyroid Storm is really when you start to see end organ damage from the thyroid. Things that you might see in Storm are confusion, severe tachycardia with heart rates in 130s, if you're starting to see arrhythmias or signs of heart failure, nausea, vomiting, diarrhea, they look jaundiced, they're having fevers, that's when you start thinking of Thyroid Storm and you want to send your patients into the emergency room to be treated. This is a chart. It's called the Birch-Wartofsky chart. It's a chart that you can, again, find on Up to Date. And it's basically a scoring system to see how likely your patient might be in Thyroid Storm. This does not definitely give you the diagnosis of Thyroid Storm. So Thyroid Storm is a clinical diagnosis, but it can sort of guide you. And so basically, it is based on some of their vitals, their temperature. Are they tachycardic? Do they have any sort of signs of heart failure like pedal edema? Are they having delirium or psychosis or seizures? Are they having any sort of GI symptoms? So you put in all their symptoms, you add up the score. If you get a score of 45 or more, it's suggestive of thyroid storm. It doesn't mean they have it for sure, but certainly that is a reason to admit a patient into the hospital. In terms of thyroid storm treatment, we generally treat with the antithyroid drugs like PTU or methimazole that we discussed at higher doses. We give steroids, beta blockers. We sort of throw the kitchen sink at them in order to bring their levels down pretty quickly in the hospital. The other thyroid emergency is Myxedema Coma. So this is with severe hypothyroidism. So when do you want to admit a patient? If you get labs as an outpatient and you're not sure of, can I treat this or do I need to admit a patient? There's not a T4 cutoff that you're looking for. It's more of symptoms. So if any patient has severe hypothyroidism and they have mental status changes, bradycardic, they're bradycardic on exam, they're hypothermic, their blood pressures are low. If you have some labs on them, they're having low blood sugars or hyponatremia. Those are all reasons to admit a patient for concern for myxedema coma, where they're going to need IV levothyroxine. So that's all I have for you today. Any questions?
Thank you so much. Go ahead. I know that Jennifer Boyd had some questions, so go ahead, Jennifer.
Sure.
That was great. Thank you. I always feel a little fuzzy on my thyroid
No problem.
diagnosis. So I'm really happy that you did this presentation. It was so clear. So I'll be happy to have the recording and the slides. So this question is actually a case. I have a patient who is on dialysis for end-stage renal disease, and he is very complicated, as you can imagine, has a lot of diagnoses. He has had levothyroxine on his med list for years, and I haven't dug back into the chart to see when that was started and what, and so forth, because he doesn't remember. So anyway, he's been off it, and he doesn't remember that he's had hypothyroidism. And I said, well, we wouldn't have been on it for any other reason, so he must have had hypothyroidism at some point. Anyway, so I did a TSH, and it was 4 point something. So I thought, I don't really think I need to start this guy back on. And I tried to look up hypothyroidism and end-stage renal disease, but I wasn't able to get the answer to my question, which is, if somebody has a diagnosis of hypothyroidism, how does dialysis affect, or does dialysis and their renal disease affect their status? So that's my question.
Yeah, that's a good question. It shouldn't be affected by their kidneys or by the end-stage renal disease. So, I would, in that patient, I would just check the TSH and the free T4. And if the T4, so right now the patient, it sounds like, is not taking the thyroid medication, to what we know.
Correct.
Yeah. And as long as the T4 is also, the free T4 is also normal with that mildly elevated TSH, then they can stay off medication. I would probably just repeat it in a couple months to make sure that that's the case. It doesn't start, the TSH doesn't start rising. But yeah, it shouldn't be affected by their kidneys.
Okay, that's very helpful. Thank you. I think that was my only question. Yeah, I think that was my only question. Thank you.
Well, thank you so much, Jennifer. That was great. Thank you so much. Does anybody else have any comments or questions?
Well, here's another question. So in a patient who has established hypothyroidism, who is on hormone replacement, there's no reason to get a T4 after that, right? You just monitor TSH.
Generally, how our lab does it, so yes, TSH is the best measure. I don't know if you, the way we order it is TSH with reflex T4. So
yeah, we can order that. Yeah.
So that's the one I like the best. So that will basically send off the T4 only if the TSH is abnormal, because that can sometimes give you more information.
Gotcha.
So that's usually what most of us order here.
Gotcha.
Great question. Thank you so much. How often does someone go from needing medication to surgery and removal of a thyroid? Is it typical more in hyper or hypo, or does that really not play a part when that occurs?
Sorry, can you repeat the question again?
How often do individuals need to remove their thyroid? Like, what's the success
Oh,
rate
okay.
of medications in hypo or hyper?
Yeah, so only in hyperthyroidism is when we consider removing the thyroid, for those symptoms. It really varies, I would say. I think in the past we sent more patients for surgery and depended on the medications less, but a lot of times now even if they're hyperthyroid, no matter what the reason, we can generally either treat with the radioactive iodine or the medications as long as they're tolerating it. I did though just have a patient, actually, I think she's in the hospital today getting her thyroid out because she could not tolerate methimazole or PTU. So she had side effects to both of those. And we gave her the option of the radioactive iodine or surgery, and she chose to go for surgery. Um, so really it's not very common that you need to take the thyroid out unless they're having other issues. Otherwise, yeah, for hypo, you don't need to take it out. And then the only other reason to take it out is if they have like compressive symptoms. So if they have thyromegaly and they're starting to have like trouble swallowing or trouble breathing, that's another indication, or thyroid cancer. So those are the things we think about for surgery.
Thank you. Do you have any questions, Terry, or any comments from anyone else? You can chat them in too. All right, I think she's doing okay. Dr. Giordano, can you stick around to talk to us a little bit after this? Still, are you still able? Yeah, you're on mute, but I think that was a yes.
I said absolutely, and thanks, Dr. Kumar. That was great.
Thank you, guys.
Elizabeth,
Bye.
Did you have that pediatric case that I had submitted? Do you remember that one?
Oh gosh, I'd have to look back in there. Did you do that recently?
I did it a couple weeks ago, but I can do it later if it's not